Good morning, everyone. Welcome to Coffee and Cases. This morning we have, I think, a pretty cool presentation from a whole team of surgeons who are going to take us through quite a complex case. But before we jump into that, just a few reminders. So always just starting off with the idea that this is a really safe space for really good conversation. If you have any questions, if you have any things to share, any experiences that you'd like to share or ask about, please do feel free to ask those questions once the presentation is complete. If you do come up with something along the way, then also feel free to put your hand up and we'll chat about it as we go. And then also just a reminder, please don't put any of your notes any of your details into the notes, into the chat. You will need to complete a register at the end of the presentation, and we'll need the word of the day to be able to earn the CPD points. Please make sure that your CPD number, your HPCSA number appears correctly in the register. It's very difficult to go and change 200 numbers after the fact. So please make sure that you put your details in correctly. We're going to start out first just with the sponsor for today's session. So today's session is sponsored by Stat Medical. So I'd love to call on Stan if he'd be super keen to share he's got a short presentation for us.
Thank you. Morning, Caleb. Morning, everyone. Will you share from your side or shall I share from my side?
You should be able to share.
Okay. I'm busy sharing now. Right. So first of all, thank you very much for the opportunity. We're very proud to be available or sponsor for the Coffee and Cases. It's a real feather in our cap. We believe that we are able to do this. And I would just like to take 1 or 2 minutes just to chat about some of the things that we provide. The first is obviously we sell a couple of the monitors and stuff that are out in the space, but we also offer training. And one of the trainings that we offer is called resuscitation or pathways. Or resuscitation pathways. And the idea behind it is that we talk about the science of CPR and why we do the things that we do. To do that, we have a goal. And the goal is we want everyone to be able to do CPR or in such a way that we can get the people that we treat home neurologically intact. And we look and focus on a couple of things. We need to start compressions early, obviously. We need to identify that patient is in cardiac arrest. We need to attach a device so that we can shock it and the arrhythmia. And we believe that everyone has a path or a role to play in the CPR that we all perform. And one of the biggest focus points at the moment is that we need to have or start to have CPR coaches that are actually not part of the resus, but are watching the resus in a manner that we improve quality. The best thing about a CPR coach is that it's
a few minutes.
Stan?
Hi, sorry. Apologies for that. I'll just share again. All right, so how do we do it? One of the methods of ensuring we do proper CPR is getting feedback. We do have devices, and most devices have some sort of feedback available at the moment. This is an example of one that I'm quite familiar with. And we're getting to a point where each compression needs to be recorded. It gives us a good indication of how we are doing the CPR, and we start to change our mentality from just doing a resus to actually titrating and using the resus now as a medicine. We focus on doing good compressions, but we're getting feedback so we can do it properly. And again, the cheapest way to do this is just to have a CPR coach. One of the things that we look at is rate. Now, the following target is our rate between 100 and 120. And my colleagues overseas had a pathways program that they offered to a hospital in Saudi Arabia. There were 100 participants, and when they were measured, this was the result. So this is without feedback, and you can see everyone is all over the place. And as soon as we add a little bit of feedback and do 30 seconds of titration, that is the result. So we can almost immediately improve rate, almost 100%. Very, very profound results. The depth, our target is between 5 and 6 centimeters. Again, without any feedback, there's quite a variability in the compression depth. And then as soon as we do a little bit of titration, we get people back into the focus area of between 5 and 6 centimeters, which makes the CPR even better. So CPR on its own, has to have a good rate and a good depth. And if we have those, then we have compressions in target. So this is rate plus depth together. And you can see we've got 1 or 2 outliers that are doing it well, but most everyone didn't. But with feedback, you can see the results are much better. So the message today is, please start thinking about resuscitations, start adding the necessary CPR coaches, and let's see if we can make a real difference. Cardiac arrest is always difficult. It's lots and lots of inputs that make it unsuccessful. But if we can start doing things properly right from the word go, we can make a difference in our patient lives. So I'd like to say thank you very much. If anyone's keen, just pop me an email and then I can chat to you. Thanks, Caleb. Thanks, everyone.
Thank you so much, Stan. Awesome. We're going to move on to the main presentation. So I'm actually going to ask Francois, who is on the call, to just introduce the team and maybe just give us a little bit of background before we jump straight into it.
Morning, everybody. So from our side, I am currently working for Boston Scientific and working with the vascular surgeons and the vascular team at Live Wilkes Hospital. So a while ago, we got a call, a referral from Highveld Mediclinic regarding a gentleman, which initially on the CT scan, it looked like the patient had a perforated or bleeding carotid artery with a threatened airway, etc. And I called Caleb. We organized that the patient gets flown to Wilkes Hospital and for the patient to go to theater. So I'm going to introduce the people that will speak. The first one is the vascular surgeons, Dr. Pine Mint, currently working at Wilkes Hospital. And then up next will be Dr. Yamin Adams, who was the anesthetist that helped that night, just from a consideration and what to keep in mind from an airway perspective, difficult airway, difficult intubation, what to do, basically do's and don'ts with a type of patient like that. And then Dr. Juanita Singh, that also did surgery on the patient. I'm going to hand over to Dr. Pinemont that will discuss the patient and what he did from his side.
Morning, everyone. Thank you for the opportunity. Essentially, this patient was roughly a 60-year-old male patient that was referred to us from Highveld, from Dr. Mabaso. Initially, he had said that this patient presented with a bit of wheezing, stridor, that got progressively worse as the days had gone by, and he had presented to his GP that morning. He's not known with any specific comorbidities per se, and he presented initially actually to the physician with this stridor and wheezing. The surgeon was then consulted and they opted to do a CT angiogram, which I'm going to share now quickly. Can everyone see the video?
Yes.
Okay. This is just a WhatsApp video that I got from the surgeon there. Essentially, it's a CT angiogram of the neck and an axial cut. And as we go on, it's a post-contrast scan. As you go on, you start mainly identifying the carotids first, and then you can see the airway being pushed towards the right side quite substantially, with a bit of narrowing of the trachea. And you can see this big hematoma with where the arrow is now was an active blush that you can see on a CT angiogram. And typically, if there's a blush like that, one can always try and go and coil the bleeding vessel. I'm just going to play it again quickly. Now, on the CT angiogram itself, it's not always easy to identify where the vessel or which vessel is the offender, to try and see what you have to go coil. So ideally, it would be to take the patient to theatre and do an on-table angiogram and see what you can coil. Obviously, in this patient, we had a bit of time. He was having stridor, but he wasn't in acute respiratory distress, that we needed to open the neck now, decompress, and go and ligate the vessel. Unfortunately, I don't have the actual on-table angiograms, but I've got pictures of it. So I'm just gonna share that now. Okay, can everyone see that? Okay, so essentially, this is the angiogram from on-table angiogram. And based on the imaging that we saw on the CT, it looked like there was a blush in that thyroid lobe, actually, more on the inferior thyroid lobe. So the main aim is then to super select that vessel and try and see where the blush is coming from. So the inferior thyroid artery comes from the first branch of the subclavian artery from the thyrocervical trunk. So what we did was we cannulated the right femoral artery, went up into that left subclavian artery and did an angiogram first. Select the thyrocervical trunk and then do an angiogram, and then get into the inferior thyroid artery. And what you can actually see here is that this is the actual main inferior thyroid artery that's going and supplying this lobe of that thyroid. And you can see these areas where there is almost like a puff of smoke. That's where the blush is. That we could identify, and well, that typically represents active bleeding instead of actual parenchymal perfusion of that thyroid lobe. And that thyroid lobe is actually quite massive, not necessarily because of the thyroid parenchyma itself, but just because of a hematoma there. So then what we did was then we opted to coil that entire vessel to basically block the flow to those bleeders. And you can see the difference from before and afterwards when you do a run from lower down. Basically, that thyroid lobe is no longer showing up or highlighting. There's no blush there anymore. So essentially, we managed to arrest the bleeding into that thyroid lobe. Because of his airway, we opted to keep him intubated for the next few days. And then we referred to Dr. Yonita Singh, who's a general surgeon, to do the thyroid lobectomy on the patient, which she did subsequently a few days afterwards. And then after that, we still kept the patient intubated for a few days, just to protect the airway. And he was then subsequently extubated, I think maybe 3 days after the lobectomy. And then the patient was then subsequently discharged. He did very well. And yeah, I know the topic that was given today was vascular injuries of the neck. So I'm just gonna just show a quick PowerPoint, I suppose, just to run through the basics of a vascular injury. Okay, so essentially, when you look at the vascular injuries of the neck, essentially we're talking about all the major vessels, and they're both arterial and venous. And one should always also consider the first part of the subclavian artery and the second part as being part of the neck as well. These are vessels that, if injured, they have to be recognized fairly early on. With a carotid as well as a vertebral artery, there's always a possibility of the patient developing a stroke. Most often than not, with an injury, whether it's blunt or penetrating, we often rather see more occlusions or dissections or pseudoaneurysm, and these patients don't often always have a stroke kind of appearance. With the subclavian, then you always have to look at the relevant upper limb as well on this affected side. Now, these neck injuries tend to occur in about 5 to 10% of severe trauma cases, and it's only isolated in about 20% of the patients. But the mortality rate can be quite significant, about 25%, especially for blunt injuries. Now, majority of the time, I actually see that femoral and popliteal arteries and brachial arteries, those account for more than 2/3 of the vascular injuries that actually take place. And the carotid only takes up about 2.2%, and subclavian also 2.2%. 2/3 is mainly the other bigger vessels. So yeah, the subclavian and carotid, as well as if we take into account the venous injuries, then it's only about 8 to 10% of vascular injuries in total. Now, the complications associated with this is obviously the bleeding and the stroke risk in these patients, but there's also other anatomy that we need to consider that's associated with it. Typically, the oropharynx as well as the esophagus can lead to aerodigestive injuries as well. And these, if missed, can have quite bad outcomes in these patients. They end up with pneumomediastinum, with sepsis inside that mediastinal tract, and these patients do very badly. Obviously, the nerves have to be taken into account, cranial nerve fallout, as well as brachial plexus injuries. And then the associated spine and head injuries, because having isolated neck injuries alone is quite rare. Now, most in our setting as well, most of the situations will be MVAs or other road traffic accidents that we see in these patients. These, especially if with seat belts, you have to look for a seat belt sign and so on, just to make sure that these patients, you're aware that these patients may have an underlying vascular neck injury. But more often than not, especially in the public setting, we used to see a lot of stab necks, gunshot necks, and so on. Those being the majority of our income back then. Yeah, the mechanisms typically either sharp or penetrating or blunt injuries. I see a lot of these stab necks with pieces of the object still stuck in. And if it's there, don't remove them. So whenever we talk about a vascular injury, we always have to look for the hard signs and the soft signs. And essentially, the hard signs are there to tell us that there is most definitely a vascular injury, whereas a soft sign basically tells us that we need to look out for a vascular injury. So the soft sign basically means that there's a possibility of a vascular injury. So if it's a hard sign with any of these symptoms, active bleeding, exsanguination, expanding hematoma, signs of distal ischemia, or withdrawal or brie, then these patients actually need to go straight to theater. There's no point in actually imaging these patients because it's just going to waste time. They're probably going to end up losing their airway or end up developing a stroke or distal ischemia. If the patient has a soft sign, then you do have time to go and image the patient and so on. And that helps us a lot, the fact that we have a hybrid theater, because then we can do on-table imaging and go selectively and see what we can do. And we might end up being able to limit the amount of surgical intervention that is actually required in these patients. With the soft signs, especially of a neck, it's typically going to be a hematoma or cranial nerve injury, or if a patient has a hoarseness of the voice, or if in those patients with suspected vascular injury. So these are going to be based on the history, so such as like a hanging or blunt force trauma to the neck and so on. Now, essentially, management is always going to be the same in these patients. First, resuscitate these patients, and the main thing is to recognize the possibility of vascular injury, underlying vascular injury in these patients. If there's any bleeding, just put a finger on it. That's going to be the best thing to stop the bleeding at that point in time. And always look for the possibility of there being an underlying hemothorax, need for an intercostal drain, and then discuss the transfer with whichever associated the associated speciality. I mean, our phones are always on, so you guys can always call us. I'm sure Francois' phone is also always on, so you can just call us at any time. We're always willing to help. When we split the neck into different zones, basically it allows us to determine what are the possible vasculature that could be involved. And we typically divide it into zone 1, zone 2, and zone 3. Zone 1 being from the clavicles to the cricoid cartilage, zone 2 being the cricoids to the angle of the mandible, and zone 3 being higher up. And the majority of the time, vascular injuries that we do see are typically zone 2 injuries. Zone 1 injuries will then also have to think about great vessels of the neck and the chest when patients have associated zone 1 injuries as well. So you have to look at the common carotid arteries, the vertebral arteries, subclavians, apices of the lung, associated aerodigestive, so esophagus and trachea, as well as the brachial plexus in zone 1. In zone 2, it's typically going to be your carotid. It's typically going to be your carotid arteries, your jugular vein, larynx, and esophagus. And in zone 3 is from the angle of the mandible to the base of the skull. So internal and external carotid arteries, your vertebral artery, and your jugular veins. So yeah, zone 2 is typically the most common that we see. And in these patients with any hard signs of vascular injury, then it's immediate exploration and repair. In zone 1 and zone 3, it's recommended to try and get imaging on these patients before exploration because of the complexity in which repairs might have to take place. You need to decide whether you have to do a sternotomy, you have to do a trapdoor, you have to do a supra and infraclavicular incision to try and control these vessels, or it's going to be a hybrid approach with the use of an occlusion balloon and then open the vessel afterwards and do either interposition repair or a bypass using most likely a synthetic graft because of the size discrepancy of these vessels. Typically with the common carotid, it's going to be a direct repair. And if that is going to be, if the direct repair itself is going to narrow the vessel quite significantly, then we perform a patch angioplasty using either a bovine patch or a PTFE patch so that we don't narrow the vessel significantly because these patients will end up with stenosis and occlusion later on in life. Same with internal carotid artery. Now, the use of shunting, and typically in trauma patients, is probably going to be less likely for you to require shunting. But one should never be when you say shunting, we're essentially saying that we put a tube down into the common carotid, and then that tube is then supplying blood higher up into the internal carotid artery, so that while you are working, there's always forward flow of blood, and the brain is perfusing. Now, whether you are a shunt, whether you use a shunt or not, you can either be an always shunter or a selective shunter, but never a non-shunter. So essentially what that means is that when the vessels are clamped, you can actually see if that side of the brain is perfusing or not based on neuromonitoring, such as your BIS or your cerebral oximetry or the use of stump pressures and so on, or the use of an EEG. If those modalities show that there's enough perfusion to the brain, then you don't actually necessarily need to shunt. And that's typically going to be in patients with a complete circle of Willis or with no impeding flow on the contralateral side. Yeah, that's the discussion about shunting. When the vertebral artery is injured, it's quite a lot more difficult to go and get to the vertebral artery simply because of its anatomy and how it runs. So the vertebral artery is basically divided into 4 parts. And essentially, the first part is where it comes off the subclavian artery. The second part is where it runs into the canal. So now it's basically covered by the spinous processes of the C spine. And in that location, it's quite challenging to try and access above and below an injury, and one might need to end up doing an osteotomy to try and get to the vessels itself. If it's V3, then it's higher up before it gets to the brain, and then V4 is in the brain itself. So in these situations, most people would actually recommend doing a hybrid approach, or just a purely endovascular approach, and go and coil embolize that vessel. With the vein, typically one can almost always just ligate the vein, especially in extremis, because fixing a vein can be quite tedious and cumbersome, and you don't necessarily always have poor outcomes when you ligate the vein itself. The subclavian artery is then injured, then is often associated with a brachial plexus injury as well. If there's no bleeding and no distal ischemia, with good saturation and with good pulse style waveform, always put a pulse oximeter on the side of the stab wound, because that gives you quite a lot of information. We do it quite commonly. Every time we have a patient with a affected limb, we put the SAS probe on that limb pre and post repair, just to give us an idea of the difference in pulse style waveform after repair of that vessel. Usually the subclavian artery is quite forgiving because there's so many collaterals that go to the subclavian and will perfuse the rest of the limb distally. And mostly it's your internal mammary and your vertebral arteries. If the patient is in extremis, rather just ligate the vessel, because these collaterals will keep that limb alive in most situations. So yeah, in summary, neck vascular injuries are quite unique and quite challenging, depending on which zones are affected. Sometimes you have multiple zones, and then you end up having to go through every possible scenario. And once the patients have associated aerodigestive injuries as well, it just makes everything more cumbersome as well. The main thing is actually just to recognize the possibility of a vascular injury in the neck, and then to expedite transfer, which I'm sure teams like Rocket can help with quite significantly. These are some cases that were done previously. We call them fall on sticks because we don't necessarily want to describe stab wounds per se, but you can see basically mucus coming out of that stab wound. So you always have to look for an associated aerodigestive injury in these patients. You can actually see the stab itself, and that's going into the oropharynx as well. This is a vertebral artery case. Essentially, that exposure is there to. It can be quite cumbersome at times. And then the expulsion of the foreign body afterwards. This is a patient that was pierced with shrapnel from a machine. Essentially, you can see that we've got good control of the common carotid artery above and below with vessel loops and Satinsky clamps afterwards. And then did a primary repair of the vessel. Blunt vascular injuries are even more cumbersome because there's so much trauma-associated soft tissue injury and so on, and it always makes dissection quite difficult. A stab wound is always easier to dissect than a blunt injury. This patient had basically absent distal pulses of the right arm, and without any saturation, no movement or sensation. So most likely a brachial plexus associated injury as well. And what we found was that there was basically a lacerated subclavian artery, the first part of the subclavian artery, and the cervical plexus roots were avulsed. So what we did was then we did an infra and a supraclavicular approach with a sternotomy, and then we did a reverse saphenous vein graft repair of that subclavian artery, and then got the neurosurgeons and the orthopods to come and do the brachial plexus roots. This is a patient with a stabbed neck to the back of the upper chest, and typically these injuries, a lot of the time, people will forget to look and examine the neck, especially when it's quite high up in the chest. But yeah, always have to look out for these associated injuries. So the main thing, as we said, resus, recognize, and then transfer the patients out as soon as possible. Okay, thank you.
Amazing. Thank you so much for that presentation. I want to maybe just pause here for a second and maybe open up to any questions from the bigger group around the vascular injury. Dirk.
Good morning. I hope you can hear me. Thank you, Caleb, for the opportunity. Doctor, I just wanted to ask, now that we have you on hand, specifically with tamponading, like penetrating neck injuries in the field, there is a little bit of variation in what people do. I believe like if you really start clamping arteries and stuff like that with penetrating trauma, I'm very hesitant. I think it could be quite dangerous, especially if you don't really know what you're clamping. But then common practice, especially in the field of ED, is to tamponade with urinary catheters, for instance, and then inflating the bulb and tamponading the bleeding that way. What I want to extend on that question is if you like have now performed the tamponading with the urinary catheter and you start seeing like lateralizing signs of ischemia or things like that, it's especially going to be considered if you're going to have like a long time to hospital. Do you stop tamponading? Do you keep that tamponade? Yeah, what is the appropriate intervention, and then what is your course of action if you start seeing signs of possible ischemia from tamponading that vessel?
Thanks for the question, Dirk. It's actually quite appropriate. Yeah, so urinary catheters, Foley's catheters are quite common practice, especially in patients with these penetrating stab wounds. The principles are that you shove in a Foley's and you inflate it, and you can even put in multiple Foley's catheters and you inflate it until you get good tamponade. At the end of the day, the principles stay the same, that it's life over limb or life over a neurological outcome per se. If a patient is bleeding out to death, you do what you can, and a Foley's catheter is going to save your ass more often than not in that situation. You might find that whatever neurological deficit the patient has afterwards, the patient might actually still recover from. But yeah, the main thing is to stop the bleeding. Initially, put your finger down and just compress while someone else gets everything ready for you, and then once you've got it, then you go from there. So I don't have any qualms with that. A lot of the trauma surgeons will also recommend the use of Foley's catheters, especially in our setting, because it's excuse.
Okay,
I think it's somebody
thank you
who
very
is
much.
not muted.
Yeah. Anyways, so
I think that was someone that was just putting your explanation into like a simple Afrikaans saying. But thank you very much, Doctor. I appreciate it. And then the agreement is to stay away from clamping.
yes,
I think
definitely.
yeah. Okay.
Clamping blind is going to cause you more problems than any solutions, because the thing is that you only have a tract that you can see. You especially in the field out there, you haven't really been able to expose the vessels in order to be able to clamp per se. So yeah, a Foley's catheter is simple, straightforward practice.
More than appropriate. I think it would be a bit of a cowboy move. Thank you, Doctor. Appreciate it.
Thanks.
Thanks, Dirk. Next, we're going to go to Carl.
Hi, Doc. Thank you for this presentation. Also from the pre-hospital setting, and this is not particular to neck injuries and that sort of thing, but when it comes to any significant penetrating trauma where there is arterial involvement and we apply hemostatic agents, whatever the brand, be it Quick Clot or there's so many out there now. As a surgeon, does that make your life quite difficult, or is it quite easy to clean that stuff out and then get to work? Does it, I mean, granted, it does help us pre-hospitally, but does it complicate things for you in theatre?
Thanks for the question. A lot of these hemostatic agents actually do not make it a more difficult scenario to repair the vessels afterwards. Obviously, some agents are easier to get rid of in theater than others. Like, for example, you mentioned quick clot. Quick clot is it's basically just a gauze. So that's easy to take off. Wound clot is another one, and that basically just forms like a gel over that bleeding site. I actually prefer wound clot, and that helps quite significantly. There are other agents that include fibrin, such as your Tisseel and Co-Seal and stuff like that from Baxter, and those typically would be in the scenario of surgical hemostasis post repair. So I wouldn't necessarily recommend those, because those can sometimes form like a very crystallized gel overlying the vessel, and to get into that vessel, or at least to clean that stuff off and then repair the vessel, is quite challenging sometimes. So I would say stick to quick clot, wound clot, stuff like that. Surgicel, there's things like fibrillar and snow. Those are also fine. Those are also easy to clean off. The powders, some powders are easier to clean off, such as Arista, rather than the Surgicel powder. The Surgicel powder I've seen is not the easiest to clean off afterwards. So yeah, I mean, your back is against the wall in these scenarios usually, especially pre-hospital. So I would say if you have something, use it rather than not, and then we'll figure it out afterwards once the patient is on the table.
Awesome. Thanks, Carl. I see, Lene, your hand is up.
Hi, yeah. So I think might be a bit out of the neck field, but considering zone 1 is almost where you'd find subclavian arteries, veins, if you've got those bad stab wounds, like where your coelitus surgeons just start to go straight, like for apex of the lung type of thing, you've got a clear vascular injury of the subclavian artery veins, I think it's a bit more difficult to tamponade them. Is there any specific advice you'd have for getting those under control? Like I work in the ED, so I'm trying to think more of trying to stop them from bleeding out or continuously auto-transfusing them before getting them to somebody who can help, other than the Foley's inside and blowing it up.
Thanks for the question. The limitations that you have in ED is probably the main problem with these kind of injuries. A Foley's, like we said, is probably going to be your best bet, and it doesn't matter how many Foleys you put in there. You can shove in as many Foleys as you can. I've seen patients walk around with 5 Foley's catheters sticking out of their necks and chest, and if that has managed to stop the bleeding, then that's great. If you're gonna put in a chest drain for these patients, try and see if you can use one of those Sinapi bottles that you can auto transfuse these patients with heparin, so you can at least save some resources. But yeah, those injuries, yes, they are very, very challenging. I think a lot of the time, the other principles that people forget is trying to do more of a hemostatic resuscitation. So by that I mean that you not necessarily a hypotensive resuscitation, but more of a hemostatic resuscitation, in that you do try and make sure that your systolics are not on the ground per se, like in hypotensive resus, but enough that the patient's GCS is still fine, and that you can palpate a peripheral pulse. In that situation, these patients' blood pressures will be somewhere between 90 and 100, and that tends to help a lot. If it's a neck injury, rather keep these patients semi-filers, decrease the drainage, and so on into that area. And yeah, those are going to be your main things. The limitation does come in what you have available in ED, and yeah, there's not really much else that you can do apart from shoving Foleys down and blowing as many up as you can until you get a tamponade.
Thanks, makes sense.
Awesome. I'd love to get across into maybe some of the airway challenges that come with these upper airway or sort of neck injuries and vascular injuries in general. I don't know, maybe if we could jump across to the rest of the team who was treating this patient.
Hi,
Hi, we can.
Mohammed. Hi, good morning. It's Mohammed Yamil Adams speaking. I was the anesthetist was assisting that night. So, everyone, we anesthetists like to say that anesthetists are like the Batman of the hospital. Nobody really knows what you do. Nobody knows where you come from. But when something goes wrong, everyone is looking for the anesthetist. And it's kind of how you feel sometimes. But I'll be a good anesthetist and just say a few words. Unfortunately, I didn't get to prepare a presentation, but I'm sure many of you guys work with such patients on a day-to-day basis. So maybe just try and visualize a patient that you've seen or airway that you were worried about and that you can maybe use as a reference. So this patient we spoke about already had this kind of spontaneous vascular issue here in the neck. That becomes important because, as Dr. Munt explained, the mechanism of the pathology is always important in deciding how you're going to manage the patient further. I mean, he spoke about blunt and penetrating injuries and so forth. For this one, some of that stuff doesn't really apply because the fascial layers in the neck assist with the compression, especially when you have these spontaneous kind of things that are happening. Whereas if you have a penetrating trauma, the swelling and the vascular kind of compression, clot and so forth traverses the cervical layers and then causes more compression. With this type of pathology, luckily, a lot of that is limited because of the body's anatomy. So if you have such a patient, you really want to assess now what is the urgency of your airway intervention. Do you need an airway intervention, and what is the urgency of the airway intervention? So you need to look.
So, guys, if you are not the presenter, please mute yourselves.
Borrowing vehicles. Now, I feel that you need to stop it because of how long it takes now with the new banking system.
I can't find this person to mute. It doesn't want to pop up. Sorry. Okay, I think we should be good. Oh, no.
The suggestion is go into your meeting request and mute everybody.
Sorry, it wouldn't pop up, but now it's there. Yeah, we can carry on.
Oh.
Who is this person? I've muted everybody.
Oh, you can't, Ms. Becker. If you feel that you want to survive, you can't give a vehicle.
Okay, I have done that.
Yeah.
Because of
weird.
TB Victor, close your mic, bruh.
Thank you, guys. Sorry, Doc.
That's okay. So you really want to assess the urgency of your airway intervention. In this particular patient, you're looking for signs of stridor, dysphonia, dyspnea. So they're really struggling to breathe, or you're hearing audible breathing. And those are signs that your airway is compromised. In trauma patients, you'd also be looking for like dysphagia or denophagia and those kind of things. In this patient, luckily, despite us being very worried about him, he had very minimal stridor. And he was able to talk to us in full sentences. Sometimes you can't really tell. You can just try and have a conversation with the patient. If they can't get out more than 2 words at a time, or they're struggling to breathe in between those in between the words, then you know something is going wrong, and that'll affect how you will decide how you're going to intervene. If you have time, these are and you feel that this patient doesn't have impending signs. Some people call these red flags of impending airway compromise. If you have time, if you feel like you have enough time, you're close enough to your hospital facility, this is perhaps not the patient that you want to try to intubate on the side of the road, or intubate it wherever that place is. If you think you have the ability to transfer the patient and get them into more favorable conditions for airway management, it's definitely a consideration. So what can you do in the meantime? Say you have this patient, you now feel that he can manage. We don't really need to intubate him right now immediately. He's still managing with his breathing. The stridor is not severe. We can still talk to him. We can still converse with him. The swelling is not too bad. What can you do to buy yourself time? So number one is you can give oxygen. Various ways you can give oxygen. You can give it with a face mask. You can give it with nasal cannulae. Ideally, in this kind of patient, you want to have some kind of CPAP or high flow nasal oxygen, which may not easily be available. However, there has been studies of people using normal nasal cannula, but at very high flow rates. And that helps. The reason that high flow nasal oxygenation is now gaining a lot of traction in airway management is because it's proven that with those high flows, that you actually have kind of stenting of the airway. The flow is so fast that it actually helps to keep the airway pregnant. When you have this machine, you can run flow rates of between 30 and 60 liters at varying oxygen concentrations. But on the side of the road, or if you're in emergency department or anywhere else, you put the nasal cannula on. You can ask the patient to close their mouth, and you turn it up as high as you can, as high as it will go. And the limitation is that the nose does get dry, and the patient does get a bit irritable with it. But it really is fantastic. We use it also for cases where we have difficult airways and we want to maintain some form of passive oxygenation while we're trying to get a definitive airway in. Then positioning, so you can help position the airway, try to sit the patient up. It will also help with venous drainage. And sometimes something for anxiety helps a lot for these patients. Remember, this is still a human being, and they are going through some form of, they can see us all panicking. They can see the panic in our eyes. If we're worried, they know something is going wrong. Sometimes they have this feeling of impending doom. They know something is going to go wrong. Something for anxiety sometimes does help a lot with these patients. Maybe just a Pofalgan. I'm sure you guys, it'll be difficult to do Presidex or that kind of thing where you are. In my setting in theater, I have access to a lot more things. I maybe wouldn't recommend it to you if you don't have a good setup. But for example, I may use something like a low dose of propofol, low dose of an opioid, or even a low dose of a benzodiazepine, just to help with anxiety. Sometimes it helps a lot with the patient. All right. So that was just kind of things you can do to buy yourself time. The last one that I forgot to mention is that you can do nebulized. You can nebulize with adrenaline. May not help a lot in this scenario, but it's worth giving it a try. Okay, so now you've now got this patient in your better setting, where you have access to a lot more tools. You still feel like you have some time. You can then try and go and delineate your airway. So CT scan might be very valuable. The surgeon will need it, and it will help you to be able to see what is the position of the airway, like, what is the position of the pathology that is affecting your airway, so that you can plan your airway intervention much more kind of academically. So in this particular patient, I think that we really only had some subglottic narrowing of the airway. The supraglottic, all of those parts above the glottis seem quite fine. So we expected that that the difficulty will not be with us actually getting the tube to the vocal cords. The difficulty may be passing it below the vocal cords. But on your CT scan, you may see a lot of other things, and that may tell you, listen, I'm going to have a problem with diaphragm ventilation, or I'm going to have a problem with laryngoscopy, and you can then plan yourself and going forward. How would you prepare yourself for your airway? This is one of the cases, these type of cases are the ones where you can never be too prepared. Luckily, we had Francois who was there before me, and he got out a whole lot of stuff that I never ended up using. But what are the kind of things that you want? You want all tubes. You want like from a size 5 all the way up to like a size 7 or a size 8. You want reinforced tubes. This is typically a patient that you would put a reinforced tube into if you have one available. Because they're working on it, that's for me. For you, not necessary out in the field or in the emergency department to be doing it. You want supraglottic devices. You want high flow nasal oxygen. You want a video laryngoscope. And then you want obviously your stuff ready for emergency tracheostomy. In terms of tracheostomy, remember that these are patients where you may not be able to feel the cricoid cartilage or the cricothyroid membrane at all. If you can't feel it when the patient is totally awake, you're not going to feel it when it's time for an emergency. So these are the kind of cases where in terms of tracheal direct tracheal access, where some would recommend that you go and locate the cricothyroid membrane before your airway intervention. If you have access to the sonar on the patient's neck, you try and locate the hyoid bone, the cricoid cartilage, the cricothyroid membrane, thyroid cartilage, and just take a marker and mark there. This is the point where the cricothyroid membrane is. So if you need it at a later stage, everyone knows where to go. Yeah, so then what do you do in terms of your, what did we do in terms of our actual airway management of this patient? We did what we call a awake video laryngoscopy. And awake video laryngoscopy means I did deep level of sedation, but still where the patient was able to maintain some form of spontaneous ventilation, and then localize the airway with some xylocaine, and then use a video laryngoscope to just kind of visualize the airway. As expected, there was no issue with getting to the vocal cords, and we were able to pass a size 5.5 reinforced tube. But what are your other options, and what does your difficult airway guidelines suggest? So in terms of what the guidelines suggest in this, which I didn't follow, but what the guidelines say is that for these patients, you should be doing an awake fiber optic intubation. An awake fiber optic intubation, if you guys have ever seen one or been involved in one, is much more difficult than it sounds. I mean, much more difficult than it sounds, yeah. Even in the best of hands, it often is very tricky and doesn't go well. You need the patient sedated, you need to localize the airway very, very well. And then you're going to be passing some form of endoscope or bronchoscope, flexible, either down the nose or down the mouth, and then entering the airway and then passing the tube over that, or while the patient is still relatively awake and breathing spontaneously. Much more difficult than it sounds, and I didn't opt for it as an option in this patient just because I didn't think the airway was going to be that difficult. In terms of the specific patient and patients with carotid injuries in general, you've got to look out at your hemodynamics very, very carefully, because you want to maintain perfusion to the brain as much as possible. You also want to limit any vascular compression that you have on the neck. And this ties in then with the idea of if you're doing a rapid sequence induction, whether you should be doing cricoid pressure or not. And these are the cases where you should not be doing cricoid pressure. You don't want to press on the neck, and often it makes it a little bit more difficult for you to intubate than it does make it easier anyway. For this patient, we then did lines, arterial line, central line, and we do something that you may not have access to out there, or nobody outside of very few theaters uses. We use cerebral co-oximetry, also processed EEG, and that helps to give us an idea of the brain perfusion. The co-oximetry is kind of like a SATS probe, but it's opened up onto a sticker, still with a red light, still with a receiver. It doesn't give you the depth that the light penetrates is not enough for you to give you a pulsatile waveform. So you're actually getting a venous saturation in the superficial structures of the head. And it gives you an idea of the oxygenation, just an idea, just an indirect measurement. Ideally, the textbooks say that the best measurement, if you are working on somebody's carotid, is an awake patient. And you can Google videos of people doing this. You can do carotid surgery in an awake patient. And then you have them awake, talking to you, looking at pictures, so that you can, and that's the best measure of knowing that a patient's brain is still alive while you're working on it. But yeah, that's about all I have to say. Is there any questions?
So we do have one question so far, Ikram. Ikram?
Yeah, hi, can you hear me?
Yes, now we can.
Yeah, good morning. So my question is for the doctor that presented first. I'd just like to just have a brief chat about the case that I had last week. So I'm a paramedic. So we arrived on scene with this guy that was stabbed in the neck and he bled profusely. We battled to stop the bleeding. We gave some TXA, but we couldn't stop the bleeding. We then took him to a secondary hospital not too far from where we were. They tried to stabilize the patient. The patient was extremely pale. I asked the doctor if we're going to give emergency bloods, and she said no. His HB is 11, and this patient's blood pressure was in it was really hypertensive. And we carried on. They inserted about 3 or 4 Foley's. Eventually, we managed to stop the bleeding. But they still did not give emergency blood. And regardless of how he was very, very pale. And then eventually when I asked again, they then agreed to give the emergency bloods. I just want to know from the doctor, please, at what stage do you, when the doctor said it was necessary because his HB was 11. So I just want to know, please, at what stage do you actually give the emergency blood? When the HB drops, or just by looking at the patient's clinical presentation with him having lost so much blood and being very, very pale? And when do you actually start with emergency blood? Thank you.
Hi, thanks for the question. I think in this situation, the first thing is as soon as the patient gets there, a cross match needs to be done and sent off and to order blood already. I would rather go with the clinical setting rather than of the HB. Chances are, I assume that when you say the HB was 11, that was based on a blood gas.
Yes, doctor, it was based on a blood gas.
Okay. Do you perhaps know what the base excess was?
No, actually, of course, we were just acting on the instructions of the doctor there because, I mean, it was a crazy moment.
Yeah.
And yeah, everybody was on hands.
Yeah, chances are usually in this type of scenario, you'll find that the base excess is like -10, -11. So the actual HB was probably sitting at about 7 in these scenarios. So I always try and teach people to go through the entire gas and not just look at the HB. And look at the clinical picture as well, like you said. And in that scenario, I would have probably already started started the patient on blood while trying to get the bleeding under control.
Thank you. Thank you very much.
See, there are some questions in the chat, so I think maybe we can just run through the chat super quick. Please don't pop your details into the chat.
I also saw some questions there. Okay, I think starting from the top, there's a question from Ruth about teaching in EM that when the platysma is breached in neck injury, that ENT are the first specialty to be consulted. That's not usually the scenario anymore, or it shouldn't be. Rather consult either a general surgeon, a trauma surgeon, or a vascular surgeon, because the ENTs tend to like to focus specifically on just their parts, and instead of looking necessarily at the rest of the patient picture. So if there is something specific that requires ENT, then we would be the ones to consult them. But yeah, if you consult a general surgeon, trauma surgeon, or vascular, then they try and take over the entirety of the management, and then refer specifically to whichever subspecialty might require intervention on. Then the next question was Foley's filled with saline. Yeah, that would be ideal. Cyclocapron injected into the wound. I haven't really seen it help that much with direct injection of it itself. Adrenaline soaked gauze is probably better than cyclocapron injected into the wound. But yes, definitely the first 3 hours after an injury, cyclocapron should be given IV. That principle still stands. After the first 3 hours, its benefit is lost with the increase of the possibility of acute kidney injury in these patients. Yeah, that's basically all the questions in the chat.
Awesome. I don't know if there's any other questions that are burning in your minds that you want to ask. If anyone has anything else that they want to bring up. Otherwise, we're going to say thank you very much for the 2 presentations and for the really, really good detail around what happens in the surgical space, but also how the EMS teams can support that patient until the patient can be brought to the appropriate center. I don't know if there's anything else that anybody else wants to add, any of the presenters. Thank you so much for your time today. I know that time is precious in your spaces.
Thanks for the invite, guys. We appreciate it. And no, it's good to share and to discuss whatever happens to patients that you guys have helped with the transfer and everything like that. I'm sure you guys have my details. So if you guys need help with any patients that you're struggling with out there, just give us a shout. Either myself or Franz will usually answer.
Thank you so much.
Caleb, I'm sorry, I'll share all the contact details and stuff, and you're more than welcome to share it with everybody that was on the call or even on the group. Yeah, and anytime where you guys need advice or just whatever, then just give us a call and we'll always help.